Welcome to this webinar, which is part of the Mental Health for All webinar series, which has been running actually since 7th April 2020 and is hosted by the Global Mental Health Action Network, which is a very large global network that consists of multiple actors who are interested in global advocacy across mental health. And just to give you a bit of an idea, these webinars have actually, I think, been over 65 webinars with over 240 speakers from more than 42 countries. In case you've missed them, or perhaps you know of people who missed today's, you can watch the recordings on the YouTube channel afterwards. And as a matter of fact, the next one, which also sounds about as exciting as this one, is going to be on sports and mental health, which is on April 30th. And in the chat, you will find ways to join GMHAN, as well as details about the very next webinar. But enough about that. My name is Raj, and I'm the director of Mariwala Health Initiative, which is an advocacy, capacity building, and grant-making organization working towards mental health for marginalized communities in India. I'm not a mental health professional, and I approach this work as a neurodivergent person, as a person with a learning disability. And in terms of accessibility, I am a brown-skinned, black-haired mostly, I have some white now, person who is wearing a red shirt and a black and white keffiyeh. So that's me. And while I will ask the panelists to introduce themselves, I'm going to set the stage for this exciting webinar that I have really been waiting eagerly for, and it is my honor to moderate, on decolonization of global mental health or mental health. And I guess just to introduce, we all know that, the Eurocentric, psychiatric, and biomedical perspective has a disproportionate power in shaping the mental health agenda. But it also shapes ideas of health, notions of productivity, functionality, and also disability. We speak about mental health, we speak about climate change, in ways that it seems like it universally impacts all people equally. But part of the issue is that we're really using measures that obscure different structural injustice. And, I think I definitely I hope that we'll be able to explore that a little more, but also to end, the predominant view of disability is also Eurocentric. And unless we challenge this model itself, we cannot talk about decolonizing mental health without decolonizing disability. Whether we are talking about Palestine, whether we are talking about Manipur in India, whether we are talking about Congo, or whether we are talking about West Papua in Indonesia, colonization is directly impacting disability and mental health outcomes. So with that, I am going to ask all of you, of course, to introduce yourselves in chat. That is the participants, everyone who's listening in today, with your name, organization, and country, while I turn this over to the panelists to introduce themselves. And after their introductions, well, actually, no, let's have a video first from a panelist who is unable to join us, and then I will ask the panelists to answer questions and introduce themselves. So if we may have the video from Bettina, who is representing the World Federation of Public Health Association, that would be great.
Decolonizing global mental health. When I first read the title, I was struck by the fact that how fundamentally these movements will change health, but change also our world. As World Federation of Public Health Associations, comprising national public health associations around the world, representing over 5 million public health professionals, we have to fully embrace these movements and to very delicately, with a lot of sensitivity, work on them. And when I heard or read the title that Antonius proposed me, and I thank him for inviting me, I was struck by another thing, and that is the two movements, global mental health and decolonizing, have several things in common. And I would think that the 3 points in common between decolonizing and global mental health that I would like to talk about are the asymmetry of power that they share. And I think it's obvious that even if you look at buildings and institutions in mental health of history and today, they really show the imbalance of power, where power is exercised about powerless people. And the same holds true for colonism. It is a complete asymmetry of power. And this imbalance in colonialism is also found in neo-colonial attitudes. But before I speak about the two other things, how we have to go about, I would like to stop a bit on the word or the term othering. Othering, humans' natural tendency is to see differences. Like children learn it very early on. But the categories themselves and the meanings associated with those categories are socially constructed rather than natural. And if you ask children in a kindergarten, for example, do you have foreigners in the kindergarten? The answer will be, we have only children. So you see the social construction behind it. Social groups develop strategies to persuade other members of the legitimacy of the way their society is organized. And most strategies, these kind of strategies, justify existing social arrangements. They are based on some form of othering, and especially othering of those who are portrayed as threatening a stable and so-called harmonious social order. And it is the amazing book of Edward Said, written already in 1978, that clearly showed how othering was used by the colonial powers, mainly England and France, to describe Eastern populations as being different and not as well off as Western population. And this served not only to validate the policies of domination and colonization, but also to justify the social order within their respective societies, based on the imaginative superiority of the Western virtues. And it's so not surprising that this analysis is still one of the basic books for the study of colonialism and its consequences. But how can we go about this? How to escape othering mechanisms that the populists in this world use very lightly and very much? I would like to introduce belongingness. Belongingness is the only viable solution to the problem of othering, and it involves inclusion and belongingness, because the most important good we distribute to each other in society is membership. But belongingness must be more than nicely expressive. it must be institutionalized as well. And that means we have to make structural changes in both mental health, colonial and colonial mental health. And we know this is hard political work. And to do so, I call on all of us that we must not only create inclusive structures, but that we must foster new identities and inclusive narratives that support us all, and this will also support the necessary political change. Thank you very much.
I cannot, I think, stress more and be more heartened by Bettina's words, especially with the idea of all of us having to do more structural work. And it actually leads us in perfectly for me to ask Emma, to introduce themselves and to ask, how have you approached indigeneity as a decolonization agenda? And what could this mean in practice for mental health advocates?
Tēnā koe Raj, tēnā koutou, tēnei te mihi atu kia koutou kua tai mai I tēnei ahi pō, ahi Māori, te mihi tuatahi ki ngā mana whenua o tēnei rohi a ko ngā tai ki tāmaki, he mihi anō nei ki a koutou katoa huri no te ao, ko Waio, ko Ngāti Ranginui, ngai te rangi raukaua me Ngāti Haua, Emma Waimari Rawson, Te-Patu, tōku ingoa. So good evening, everybody. I've just addressed you in my native tongue, Te Reo Māori, and I've done a couple of important things. The first thing is to acknowledge you, Raj, as the facilitator this evening. Thank you for having me. Most importantly, I've acknowledged the tribal group of the land on which I'm standing currently here in Auckland, New Zealand. I'm actually in the southeast of Auckland, and the tribal group here is Ngātai ki Tāmaki. There are others also to address in this particular area, but they are the key one for me to acknowledge this evening, as well as all of you around the rest of the world, wherever you are, at whichever time of the day you are at. Again, it's my honour to be here this evening, so thank you for having me. In terms of how are we addressing indigeneity and decolonising, in particular regard to the World Federation, of which I will become the first Indigenous woman to be the president in May this year, which is a significant opportunity for the Federation in and of itself. We were very pleased to be able to establish in 2017 an Indigenous working group for the Federation. Again, first time in its history, and a very quick formation of that type of working group at this level. And what I must say about this in terms of practice, one of the key points in terms of practice, no matter where we're practicing this, is about leadership. And the Federation has demonstrated absolute, authentic leadership and leaning into the bravery around the conversation around decolonising public health. And as you all know, public health is around the determinants of health. So everybody's access to those things that enable them to be as well as they possibly can be, no matter what that means. And so we've been really clear as our Indigenous working group, which have mostly been formed by Indigenous peoples from first world countries like myself, acknowledging that there are many faces of indigeneity. We've been able to work together quite quickly from our position of strength in the countries where we're from to be able to begin to determine and define for the Federation what it means to decolonise the Federation. So we're really clear that we're not trying to do everything, but we know the space we're in. And the biggest thing around our space is encouraging people along the journey, which mostly is around socialising them to the term itself. Because as we all know, there's a lot of fear involved in this process. There's a lot of confusion about where to focus. And when I talk about focus, one of the main things for us is really needing to lean into acknowledging the place of indigeneity at the beginning of the conversation around decolonising. Often it gets distracted by other forms of social justice that claim this description, which are not actually doing decolonising. So we need to be really clear about our understanding of what that means and the context that we live in and how we are to apply it in the context in which we live in. So as I've described before, I'm an Indigenous woman from a first world country. Many people are many other definitions of things that have been affected by this. And so for those of us who, or those in our communities who are our allies, the biggest thing I would say to them is know your context, know your history, understand what decolonising means in its truest sense, and then you can actually move forward with authentic and sustainable action. That's what we're doing at the Federation level. So again, authentically leaning into the place of Indigenous voices in public health at that global level, sharing power and decision-making at that global level with our Indigenous voices has been really key for the Federation. And again, the manifestation of going to have a president who's Indigenous is again the very big sign of that. The other thing that we have done through this work is we have adopted last year in May a goal for the Federation of systems change and decolonising public health. So this is part of what Bettina talks about when she's saying institutionalising the change. So we've adopted that goal, and hopefully in May this year we will have 2 policy position statements for the Federation. One is on Indigenous health and the other one is on decolonising public health. So there are tools immediately that others in our association, and as she mentioned, 5 million members, can begin to apply to their own associations and in their own countries. And we hope the byproduct of that will be more of these occasions to be able to share our work and work in collegiality and partnership with all of the other people who are leaning into this space and work in support. I think I've probably spoken quite a bit, so I might leave it at that and wait for the question and answer session to see if there's more to add. So thank you.
Thank you so much, Emma, and we look forward to learning from your leadership and to continue work in solidarity with you and your work, as well as hoping that psychiatric and mental health institutions in places like the USA and the UK follow the lead of the Federation. Let's switch gears a bit, and I'm going to ask Rami about a topic I think that is on everyone's minds, of course, and what have you learned from your work in Palestine and elsewhere about decolonization? And what does this mean at this point in time for mental health and psychology? And further, if you could give us a few words on the Indigenous Palestinian practice of Sumud. Thanks, Rami.
Hello, everyone. I'm grateful to be sharing this space with panelists from different rich cultural contexts. I think such diversity in knowing and doing, I believe, is key for advancing a decolonized global mental health, one that is capable of allowing different types of knowledge and knowing to sit easy side by side, and one that does not conceive of global as universal, which at oftentimes meant an imposition of one way of knowing or doing as superior or scientific and other as inferior or irrelevant. So I'm really grateful to be here, and I hope this discussion generates both a fruitful experience of learning and unlearning for our audience. I would like to answer this question by starting with the other side of the coin, because I feel also whenever we speak about decolonization, people think it's just a buzzword and that we're overusing it and it's a metaphor. And also, I would like to talk mainly about coloniality, which means despite the absence of territorial colonization, coloniality means the power and knowledge continues to oppress and dominate us. And power is all around us in the institutions we work in, and the universities, especially in the Imperial West. And to give a brief actual experience about coloniality based on my work, so that we don't think about coloniality in abstract terms, I've started working in Lebanon refugee camps, which are camps that were made after the 1948 Nakba in Lebanon for the Palestinian refugees. And I've worked there for many years with NGOs and humanitarian organizations, mainly working in psychosocial support with the children and teaching children about emotions and children's rights. And I've always been frustrated that most of those curriculums were developed in the West without consulting us. So I was curious to know who writes those curriculums and based on what theories, and why do they not address our history as people and name the oppressor when we work with children? Because when you work with children in a camp, how can you answer the question if a child asks you, why am I a refugee? Or why can't I go back to Palestine? Those are not written in those curriculums and they are not addressed. So when I went to Europe to study psychology, mainly I did a program that teach us how to translate theory into intervention. I started finding or understanding the meaning of coloniality that I was subjected to. I started understanding this relationship I had to institutions, to the West, to knowledge, which oftentimes ignores our own knowledge, the knowledge that is born out of struggle, the knowledge that names the perpetrator explicitly. It is related to our history, to our language, to our ancestors' experiences. And I was not surprised to find that most of the theories that we study are mainly or predominantly written by white men. And most of the psychology literature continue to see Palestinians in apolitical terms or psychopathologize them, that they are merely depressed, anxious, but they never ask why. They never try to target the root causes of oppression, which is settler colonialism in Palestine. So coloniality is not abstract. Coloniality is something that we still experience. And at this point in time, if we ask what decolonization means, we also have to understand the history of coloniality that is still ongoing. The psychology, for example, has always been used as a tool for colonization to oppress indigenous people in North America and elsewhere. So is research on vaccine. So is in agriculture, what the colonizers did in Martinique, for example, when they tried to use fertilizers. Their land is still poisoned until today. So coloniality is, and the oppression and the violence of coloniality is still ongoing today. Unfortunately, we live at a time that coloniality and colonization nowadays are being televised on TV. They moved past just knowledge in abstract way. They moved past the university to manifest an ongoing genocide that the whole world sits silent. And we still ask what decolonization means. Decolonization means being critically conscious and aware and reflect on the power that surrounds us, that is in institutions, that is in everything we are doing, especially in the West. So what decolonization means is we have to stand up and stop the genocide that is happening with whatever means that we have. If we are health practitioners, we have to see and insist on seeing our profession as political. And this is what Western liberal health tries to separate humanitarianism from politics, which at oftentimes is fused together. And that's what leads me to talk about the indigenous practice of Palestinian Sumud. So Sumud translates into steadfastness, and it has a long history of resisting oppression and domination in Palestine. It goes back to the British Mandate, and it is very tightly connected to the Palestinian peasant that has always experienced oppression by the Ottomans, and then by the British Mandate, and then by the Zionists through land grabbing, tax, violence, and all of that. And after 1948, Sumud has taken different forms because most of the Palestinians were expelled, they were scattered across the world. But Sumud remained a very significant part of their culture because it is derived from their connection to the land. We see land as an epistemological site that nurtures certain values and traditions, mainly our right to return, and our firm belief in justice. At some points, Sumud has been also connected with institutions. It has been institutionalized. So we had, especially in Lebanon during the 70s, where the PLO took base, And healthcare at that time was revolutionary by all means. It was political, and I'll finish in a sec. So healthcare at that time was both political and humanitarian. And I just want to end by saying Palestinians has always used healthcare as a practice of resistance, and we have to look at what's happening in Palestine nowadays to see how the colonizers often used healthcare as a site of death, as a weapon of death, with their deliberate target of hospitals, of universities, of practitioners, and we have the duty to respond to that with all means we can. Thank you.
Thank you, Rami, for that. Especially the idea that, you know, the default, the hegemon is never defined, and it is so powerful. So thank you for defining that default for us, you know, as well as all your insights on Sumud and the fact that we have to change the master's tool and healthcare is resistance. Thank you for that powerful thought. Before I move on to the next speaker, in case you have questions for our panelists, please send them over the Q&A function because question time is happening soon. But now I will move to my very good old friend, Victor, because I want him to tell us about what it means to center youth as the foundation for a decolonized future for global mental health, and how could we achieve this?
Thanks a lot, Raj. It's good to see you again. My name is Victor Ogo. I work with a MHPSS collaborative, which is hosted by State Region in Denmark. And we are focused on research, learning, and innovation for children, young people, and families facing adversity. It's really great to be on this panel with a lot of people that I've seen and known and who I admire a lot. And when the promotion for this webinar was posted on LinkedIn, I saw a comment that really got me thinking. And I've come across it a lot in similar fora. The person said, decolonization is just a buzzword, and I'm just paraphrasing here. I would kindly beg to differ, however, at least in my own humble opinion, and for where I'm sitting as a young, I still think I'm young, Nigerian, with my own lived experience of mental health issues, who has struggled a lot with the many different ways of understanding what I'm going through, or articulating it in the best terms that fits the current scope of language and approaches of treatment and recovery, which most times I'm being offered, but which are sometimes in complete disconnect with my culture and upbringing and the way that I have understood healing and recovery. So permit me to take the first couple of minutes in my intervention to argue, as we all do now and then with people on the internet. Decolonizing global mental health is not just a buzzword. For me, it's a profound shift away from the harmful legacy of a colonial mindset, which, among other things, has contributed to the erosion of traditional healing practices, spirituality, and community support systems that play a very key role in many cultures' understanding of mental health. For me, it's about revisiting the language, the diagnostic classification systems, the approaches to recovery that have been developed by Western context, but applied in other settings without or with very minimal questioning or in-depth adaptation in recognition of culture and context sensitivity. It's about more than where just aid money comes from. It's about whose experiences and expertise guide the language that's used as a foundation for the development of mental health frameworks and systems of support in the very first place. And for me, means critically examining the ways in which Western-centric biological models, assumptions, and even funding mechanisms have shaped the field and how we understand and deal with mental distress. Now, this narrow focus can, of course, overlook the critical social, cultural, and economic factors in shaping mental health and well-being, especially in context where I'm working at, in context of displacement, conflict, or oppression. As a matter of fact, what we call true decolonization means moving beyond well-intentioned outsider experts and towards community-led and culturally sensitive approaches. And it means recognizing that those that are closest to the challenges often have the deepest insights into the solution. And among the most people affected by this are young people, and that's going to be my focus for today. Now, young people, as we know, I'm going to be preaching to the choir here. They aren't just a vulnerable group in need of support. They're a vital force for positive change within their own communities. You know this, we know this, everyone knows this. They're very creative, they're adaptable, their understanding of local realities make them very powerful proponents for a decolonized future for global mental health. However, centering youth in decolonizing global mental health demands a revolution in how we think. It means moving beyond seeing them as just beneficiaries and recognizing their potential as problem solvers, innovators, and agents of change. It means strengthening their pre-existing capacity to lead in shaping services and policies that resonate with both current and future generations. Now, back in March 2023, at the Collaborative, we decided to explore research in partnership with some graduate students from the Geneva College Institute to look at interrogating existing frameworks for how to integrate youth leadership into mental health and psychosocial support responses in humanitarian emergencies. Now, this research revealed a burning desire, and I feel like I'm underestimating this, a huge desire among young people to contribute to mental health solutions within their own communities. They're very frustrated with being seen as passive recipients of care. They're yearning for active roles in shaping the support that they receive. But sadly, what we see is that this desire to contribute is often dismissed or very much underestimated. Young people are perceived as inexperienced or their ideas are not yet fully formed. Now, this mirrors the same top-down, outsider-driven models that have dominated the mental health sector for a long time and which contribute to the very problems that we're discussing today and that we're trying to solve. For example, we encountered examples of youth-led initiatives that were stifled by a lack of trust and resources. In fact, one young participant said he described the challenges that they faced in securing funding because their project was deemed too small or too lacking of experience by traditional donors. Now, this is something that we've come across in so many ways and so many times in our work. These findings from this research, they underscore the urgency of a paradigm shift. Instead of thinking about perpetuating dependency as we do, we must create sustainable pathways that facilitate young people's leadership in global mental health. Now, this thinking is what has led us to a new initiative that we've been co-developing with young people for the past 1 year plus, and we're hoping to have that launched soon. For now, we're calling it the Youth MHPSS Fellowship, but this is a program that not only provides training in the fundamentals of mental health support, but also in practical skills like community engagement, needs assessment, advocacy, and program management. For us, it's about an opportunity to create a new generation of mental health professionals that are equipped to drive a bottom-up, locally led approach. Ultimately, and just in conclusion, right, decolonization of global mental health is about ensuring a future where mental health support at every level, and I cannot say this enough, at every level, truly reflects and addresses the needs of the communities that it serves. And centering youth in that vision is not just one of the ways to do it, but it might just be the most important and future-proof approach to assure a world 10, 20 years from now where this is no longer a conversation to be had, but it becomes a relic that we can put behind us once and for all.
Thanks, Victor. And just to ensure that we don't have very dominant ideas of youth, I'm going to ask Jian for some of the reflections that you may have from working in the mental health sector with youth and grassroots communities in Indonesia. Over to you.
Thank you, Raj. Always a pleasure to meet you and others here. I think I would like to pick up on what's been mentioned before. I think Rami brought a very good point about knowledge and how it's produced, by who, perpetuated, and it benefits whom, right? The production of knowledge, especially in regards to knowledge of mental health, how we perceive it. Is it individual? Is it collective? And I think just as a disclaimer, I would like to speak just from my personal experience here, very limited. So sorry if I misrepresented or anything, because I'm also here to learn. And I think from my experience, I was in a position of what Victor said, like beneficiary in the past. I was in a position of a partner, of a worker in a development project, and especially in regards to mental health for several years. Funded by many like governments or even private sectors. And I always see that an elephant in the room has always been, who are we doing this for? Like this project, like this benefits whom? Like when we talk about, oh yeah, it's for the greater good, it's to improve, because we see statistically, there's a lot of people with living with schizophrenia, anxiety, depression. But it's always been what they refer to in the proposals, in the early discussion, has always been what I call as a cold data. A cold data that is like statistics, numbers, that is prone to have its own downsides, as well as it does not capture the complexities of a country, of a region, which has a long history of context, has been mentioned by my previous friends before. History of colonization, history of exploitation, history of even not only the colonization by so quote unquote foreign countries, but also among their own basically citizens and governments towards their own people. Because colonizing is actually a way of practicing subjugation, right? Domination towards a certain group of people in order to benefit the others. And I think in relates to mental health, who are we doing it for? And when we only refer to those cold datas and see mental health as a apolitical being of subject, like it's been mentioned before, it's try to separate it, right, between the social determinants in health, social context, and the health side of it, and see it merely as an individual thing, then who does it benefit for? Like, it looks good on the report, you get, yeah, great, you get some awards for funding these projects, congratulations, and you get like a lot of beneficiaries and something to be proud of, right? But is it meaningful? Is it really beneficial for the people who are supposed to be called the beneficiaries? And do they have what I think one of my favorite intellectuals said, like, can the so-called subaltern speak? Can the people who actually, the beneficiaries in the global south, which is a very sanitized way of saying third world country, it used to be something we were proud of, right? Third world country, not like in a very bad connotation like today. Like, who does it benefit of? I think it requires us to rethink a radical way of not only funding, not only implementing projects in mental health, but also like how the knowledge is being produced. Can we actually capture what I call not cold data, but warm data? Warm data is actually what some people say, oh, it's too subjective. Oh, local custom, indigenous cultures, it's too, basically debatable. And then seeing history as something always moves forward. But sometimes we can learn some from past parts of our history. But the question is, do we want to? The question is, do the people who support us doing these projects want to do it? I mean, it takes quite a lot of work by asking a community be a part of the solution, not only part of the basically a beneficiary. So I think my point from my experience is the power relation has always been there. We need to take further steps, I think, in decolonizing more than as a jargon, but also to rethink the questions we want to bring in our projects, in our fundings. Not only bring forth solution before we even know the problems, and involving the people who actually can be a part of the solution themselves, that we want to invite ourselves to be in part of their conversation with. I think I'm here to, once again, is to reflect and be in solidarity with everyone who is subjugated, who is exploited, who is repressed. It's about time for us to not see mental health as something apolitical, to divorce it from social determinants, from colonization, from occupation, but also to see it as a whole picture, so that we can understand things better before we even claim to have solutions for it. Maybe that's from me, Raj, and thank you. Sorry if I take too much time.
Thank you, Gian. That was absolutely amazing and rousing, especially the call to not jump to solutions. It's one of my pain points when it comes to global mental health. We will shift, however, to asking question and answers that all of you all have so kindly put into the chat. And this one is for anyone who'd like to answer from the panelists. Is there any work being done to integrate or build mental health systems that are cognizant of Indigenous knowledge or addressing mental health issues?
I might have a go at answering that. So in New Zealand for decades, we've been, attempting to do this in a number of ways. And most significantly, it's been through the use of frameworks that have been developed by our own people to be utilised within the systems to help to shift the system to deliver the services that our people best need. And so that goes along with our process of reclamation and the fighting against the process of colonisation, which has been really around trying to shift the balance of power in terms of decision making and who is distributing the resources that then creates the services. What we were able to get in most recent years was for the entire health system, a remarkable setup, which meant that we had essentially two bodies within our health ministry. And one of those bodies was an Indigenous body, and it was charged with a number of things. Among those was monitoring the mainstream health system and commissioning for services that were determined by our people, the way we needed them to be delivered. And when I say that, we acknowledge the fact that the faces of Indigeneity, even within New Zealand, are not homogenous. And so this is around choice, it's around power sharing and who and how decisions are made. And so we have made great progress in that area. That particular model at our central government system has been the best in terms of beginning to disseminate the power in a much more equitable fashion so that all of our health services, in particular mental health services in New Zealand, because our people are most affected by suicide and other mental unwellness. But unfortunately, politics has a huge role to play in this, of course, and we all know this. And unfortunately, that particular system has just been disestablished by our new right-leaning government. So we're all reeling here quite a bit because such a significant gain can be taken away so easily. But we are emboldened by that, and we are emboldened also by the allies around us who are also beside us wanting these types of models of partnership between Indigenous peoples and others to remain. So there's somewhat of an answer. Thanks.
Thank you so much, Emma. And for my co-panelists, I put in some responses in the answer form. So if you'd like to look at the questions yourself and answer by typing them out, that would be great. Again, the next question is for anyone who'd like to answer, which is from Stella, and it is, how can we include psychologists' evidence on journey of the client as we advocate for decolonization of mental health? I'm wondering whether I can put you on the spot, Rami.
Sorry, I was reading the Q&A. Can you please repeat the question?
So Stella asks, how can we include psychologists' evidence on the journey of the client as we advocate for the decolonization of mental health?
Yeah, it's a big question. I would go back to say we have to be very wary and conscious of the context, just as Emma mentioned, that we have to really know the historical context, the political context of whatever client we're working with, before we just sit in our comfortable offices, wherever we are, and draft that, starting by questions, the questions in themselves, or the thought of putting a question involves a power dynamic between you and the client. So I think learning about that history and learning about the context is a way to go forward and to be sensitive to what can be asked, what cannot be asked, and to take it from there. But I cannot offer a general answer. So thank you.
Thank you, Rami. Thank you. Anyone else would like to say anything from the panelists? Okay, looks like not. Okay, there is a question on research and grant proposals. And the author says there are many research and grant proposals from the global north to be implemented mostly in LMICs, which is the global south. But despite the struggle of decolonizing global health, we still see the PI should be from the global north, which shows their attitude of poor capacity or performance if the PI is from the global south. What is your say on such issues? Again, I think this is open to everyone.
I can definitely respond to that. I think it's a huge assumption to say that the reason why the PI is from the global north, south, not from the south, is because of a lack of capacity or reduction in performances. And I think it still boils onto the issue of where most of the funding comes from and the lack of trust in the system in the first place. Now, this is not to say that there is not there are not times when funders actually also have PIs from Global South. That's happening more frequently. So I think just to acknowledge that. But one of the issues with this is that lack of trust, that it's just general across global mental health when it comes to who you fund, who you trust to give your money to, whether they have the pre-existing capacity or not. There's no assumption or question of capacity when it comes with a PI from the Global South. Whenever it links to global from Global North, whenever it links to Global South, there's always questions about, do you need capacity? Can we find someone who you can pair up with, who you can do this with? So it's really just about existing cultures of funding and has nothing to do with the poor capacity or performance of the PI in Global South.
Thank you, Victor. I'm going to switch to a question from Vasudha, which is, what do you think about the concept of ethnic matching that has been suggested as a way to decolonize mental health therapeutic practices? Is it helpful, or is it just another way to distract from deeper systemic issues with mental health education and training? One that is deeply informed by data or research in weird demographics, as Rami referenced. And I think WEIRD stands for Western, Educated, Industrialized, Rich, and Democratic. Yes, anyone can answer this. Gian, or maybe, I'm sorry, Rami, I think I'm putting you on the spot because you were referenced in the question.
The thing is, I'm trying to answer the questions that were put in the Q&A by typing, because some of them were, that's why I'm in both. Yeah. I can't hear you because it's mute. Yeah.
I said we can switch to another question and maybe come back if we have more time for this one, so that you have time to respond in chat if you'd like or prefer. But let's switch to, how does mental health for all, which is formal or non-formal support, look like when basic needs haven't been met? How can organizations, individuals, mental health practitioners provide support when signposting or referral doesn't fulfill these needs? And perhaps I'll put you on the spot, Gian, since we haven't yet heard from you in Q&A.
Thank you, Raj. I think the support, what we have to understand by acknowledging the complexities of global South countries and mostly undemocratic, authoritarian, and very basically people living without social security, etc., is to acknowledge that context and what can we do about it? What can we do to make sure that this so-called project that we're going to do with them, not for them, is going to be beneficial for all, especially meaningful for them. So I think this is also a reflection, because I've also worked, I met Raj several times before on several global initiatives, right? And I think they tend to have this kind of rule, like, okay, for budgets, for staffing is less than 30%, 25% only, and then that doesn't include the office rent, that doesn't include everything else, not even security measures, not even mental health support for the care workers themselves, for the people who are running the projects themselves, and even though they are facing extra burden. So I think this is very, like, it's about like giving the right kind of support that actually basically providing the right kind of support that captures the complexity of that country, and that cannot be done without actually involving the people in those country to actually explain their context, which is why I think I'm also a part of Being Initiative, and what Being Initiative done so far is actually they do is they learn and then they invest. So the learning part is actually they do a basic kind of like research of what do they actually need, how the country works and everything, the context. So then when they are going to open call for proposals and everything, it's going to nail those points that actually needed by the countries and told by the people from those country and the community themselves, I think. And I also just weigh in on what Victor answered before. Actually, I wanted to answer the previous question regarding the PI from Global South. I think we have to be treading very careful not to jump into like very, very meritocratic way, in a way that is like sometimes if we jump directly to the meritocratic by saying, okay, people in global south have the same capacity like global north, and then not acknowledging the social complexities that they have, like the oppression and everything, right? The scarcity, the vulnerabilities that they have just by living and breathing as a citizen of that country. Actually, how meaningful do you want your project with? Then you cannot just assume everyone has the same starting point, including your PI. So I think that's something to be acknowledged for as well. I think that's from me.
Yeah, I was just going to add to that, Raj, if you don't mind, in terms of how does mental health for all look like when basic needs haven't been met, and how can organizations provide support when signposting and referral doesn't exist. I think the starting point is like Jian said, just exploring and looking to find what are existing practices for healing and recovery in this context, because we already make the assumption that by if we get into the system where there's no referral support systems and you cannot signpost, that it becomes difficult to operate. But the thing is, people in those contexts have been living there for a while. They have their own understanding of resilience. They have the things that they do to cope. And that's what we need to be building on without trying to force them into, again, the biological Western-centric models of care that has them going to the hospitals. And there are people in some contexts that prefer using traditional healing practices. And there's some research on that. I think there's a research by in Ibadan by a university professor that I know and admire so much, where he looks at how they can pair up the existing practices for traditional healing with existing practices for community-based mental health support. So I think everyone has what they do that works for them, and coming to tell them that this doesn't work, this is exactly what you should try, is not the way to get people to be part of a conversation.
Thank you, Victor. And, there's so many brilliant questions in chat that I hate doing this, but we must, because we must wrap up. But the good thing is that this webinar is just a beginning to this topic, and I'm sure that there's going to be much more focused and in-depth work on this from GMHAN. So hang on to your seats, folks, and keep on tuning in. But for now, I'm actually going to go to wrap up and put all my co-panelists on the spot in order to give us some insights on thinking what taking action could mean about this huge topic. And so I want you to complete this tweet-length statement in one sentence. And the statement is, for a decolonized global mental health future, Action Network members can, we can start with maybe Jian.
Maybe we can start with the others.
Okay, how about Emma then?
Thanks, Raj. So members can understand their context, understand their history, be leaders in the space as much as they possibly can be, show by example, and just know how to be a good ally in the space.
Thank you. Brilliant. Victor, would you like to go next?
Yeah, so for a decolonized global mental health future, Action Network members can and should advocate for policy changes and practices that center youth leadership. They need to demand that youth voices are included in decision-making bodies, promote participatory research models, and challenge traditional funding mechanisms that exclude young people.
Thank you, Victor. Rami, how about you?
I think we shall perceive knowledge in a pluriversal sense, as I started in my introduction, and value unlearning as much as we value learning. I think our society keeps emphasizing learning, but I think also unlearning is the difficult and important task to do, because it requires critical thinking and reflecting and always taking action.
Thank you, Rami. This is so exciting to hear from everyone. Very actionable stuff. So Jian, over to you.
Yeah, I was just very happy Rami brought up about unlearning, and that's exactly what I want to echo. Unlearning. Don't be afraid to rethink the question that we would like to answer in the first place, the problems that we would like to give solutions for. Don't be afraid to rethink, to unlearn, and basically to capture the complexities. And if you don't know where to start, I think there's a lot of people in the chat box, in the question and answer panel. Basically, they want to start. How can I begin? Maybe start from listening. Start from listening and finding the people that you're willing to listen to, and not to interrupt, not to put your words over them, but really listen to their lived experience. Because nowadays, of course, I think we all agree, lived experience is a very great asset for mental health and the advancement of mental health globally. So yeah, basically data production of knowledge the way we decolonize it is basically one listening at a time, basically one empathy at a time, trying to acknowledge what comes before us and try not to forget that, because not everything changes just because one event. Yeah, if you know, not everything changes just one event. It's like years and years, decades of oppression, of exploitation. We need to capture that part as well in order for us to really make an advancement that is inclusive and basically beneficial for everyone, not just the few. That's for me.
Thank you, Gian. And I was asked to give one as well. So for me, it is, for a decolonized global mental health future, Action Network members can foreground counter narratives of structurally oppressed communities at the very heart of learning and as valid producers of knowledge. That being said, I really want to thank all the panelists for an absolutely enthralling discussion, as well as the audience really for being so fully engaged in this important topic and this conversation. And here's to many more such conversations and work. We have leaders now at the helm who will be guiding us. Thank you, Emma. And of course, this conversation can continue on GMHN Circle. The link to join this will be in the chat. And of course, there is the next one coming up, I think on April 30th. So let's continue this. As Bettina said, it's going to take work from all of us. Thank you, everyone.